We're very blessed by having three expert speakers who are going to be telling us about a really important aspect, I think, of scaling cardiac rehab, which is the whole area of digital cardiac rehabilitation. So I'll hand over to my co-chair in just a second, but before I do, just to remind you that today's seminar is a little bit longer because we have three speakers, so we have 90 minutes if you're able to join us. Usual rules, please. Can you put your camera off and keep yourself mute? But there will be an opportunity for questions and answers, which we will do at the end of the session after the three speakers have spoken. So if you do have any questions, and we would really encourage you to participate, please put them in the chat. Hopefully you can see the chat function at the top of your screen with a little voice symbol. If you can put your comments in or questions in the chat, myself and the Glasgow team will be checking those during the presentation. And then what we will do is we'll then pick up those questions at the end, and maybe if we've got time, we can take some live questions as well. So I think that's everything from me. Now my pleasure to hand over to my co-chair, and a real pleasure, Bilal Ahmad Khan. Bilal is one of our across PhD students based in Pakistan. Bilal is particularly focusing on digital cardiac rehab. And Bilal, you're going to chair the next session of the seminar. So over to you. Thank you very much.
Thank you so much, Professor, for the kind introduction. And thank you to our speakers for joining the meeting. So as mentioned by Professor Rod, I'm PhD scholar in the Across project, and my aim is to develop the digital app for the people of Pakistan here. So let me introduce our first speaker, which is Malene Hansen, who is a PhD student and a cardiac nurse at Heart and Genetov Hospital at the University of Copenhagen, Denmark. Her research focuses on rehabilitation and self-management support for patients with heart failure. And our next speaker will be Kaitlyn and McGill, who both are the part of NHS Lothian's heart manual team. Kaitlyn is the heart manual specialist practitioner who has experience of being both an exercise physiologist and a cardiac rehabilitation physiotherapist. Kayleigh is the heart manual assistant psychologist, and her professional background is in heart psychology, health psychology, and research. And our last speaker is Samantha Buerden, who is a social research fellow in the Health and Community Sciences Department at the University of Exeter Medical School with a background in psychology and behavior medicines. Her work is focused on the development, evaluation, and implementation of health behavior change intervention, and has a particular interest in the utility and uptake of digital health and integrating key stakeholder involvement throughout the life cycle of intervention. So I hand over to our first speaker today, who is Malene Hansen. Please, if you can share your screen and continue.
Okay, thank you. Bilal. I will just share my screen here. So I'm on. Yeah, good morning, everyone, or maybe good afternoon in Pakistan and Bangladesh. So as Bilal said, my name is Malene Hansen, and I'm a PhD student and a heart failure nurse from Herlev Hospital in Copenhagen in Denmark. So today I would like to share some findings from the Danish REACH-HF feasibility study. And in this study, we evaluated a home-based cardiac rehabilitation program for people living with heart failure and their caregivers. So I will briefly introduce the program. I will present some of the main findings from our study, and then I will also share some of our experiences with the digital part of the program due to the topic for today. So before introducing the program, I would like to briefly explain why we felt there was a need for an alternative or different approach to cardiac rehabilitation here in Denmark. So we know that cardiac rehabilitation improves quality of life, self-care, and other clinical outcomes for people living with heart failure. However, participation is still lower than we would like to see. So in Denmark, healthcare is publicly funded and cardiac rehabilitation is offered free of charge. And even so, only around half of patients with heart failure are referred to rehabilitation. And then we, of course, also know that among those who are referred, many never start or do not complete the program. So the barriers to participation are well known. So in Denmark, traditional cardiac rehabilitation is usually a center-based offer, either at the hospital or in the municipalities. And patients are then expected to travel to the hospital or rehabilitation center. They are expected to attend at fixed times and often also participate in group-based sessions. So for many patients, these factors become barriers to participation, maybe especially for the older patients, people living with many chronic conditions, maybe also for people who are still working, or those who simply just need a more flexible way of taking part. And of course, this is not only a Danish challenge. Similar barriers have been reported in many other countries, including the UK and maybe also the same in Pakistan and Bangladesh. So here in Denmark, we asked ourselves a simple question, maybe not that simple, but how can we make cardiac rehabilitation more accessible for patients who do not participate in conventional programs? And one possible answer is maybe to offer a home-based cardiac rehabilitation program. And that is where the REACH comes in. So to address some of these challenges that I just mentioned before, we looked to REACH HF, a home-based rehabilitation program originally developed in the UK. So rather than developing a completely new intervention, we wanted to build on a program that already had a strong evidence base. So our goal was to preserve the core components of REACH HF while adapting the program to fit into Danish patients, to the Danish healthcare professionals, and of course also to Danish rehabilitation pathways. So the adaptation process involved patients, caregivers, nurses, physiotherapists, researchers, and stakeholders from both hospital and municipal setting, where rehab are offered in Denmark. And this was, of course, important because we wanted the program to fit into the Danish healthcare system, not only to translate the materials into Danish. So one important addition during this adaptation process was the introduction of a digital delivery option through the national platform called My Life, My Health. So this allowed patients to access rehabilitation resources digitally in addition to the traditional printed materials. So the final Danish version maintained the core REACH HF principles while adding maybe a greater flexibility in how patients could assess the program by introducing this digital app. So once the program had been adapted, the next step for us was to see whether it could actually work in a Danish healthcare setting. So we therefore conducted a multi-center feasibility study across 3 sites, including 1 hospital and 2 municipalities. And we recruited 71 patients with heart failure. Importantly, these were patients who had declined conventional center-based rehabilitation. They were then offered the DK REACH program. So in other words, they were exactly the group we were hoping to reach. So participants then received a 12-week home-based cardiac rehabilitation program delivered by trained nurses and physiotherapists, the so-called facilitators. And the program followed the same overall principles as conventional cardiac rehabilitation, and of course also in line with national and international guidelines. But instead of attending the sessions at a rehabilitation center, participants completed the program in their own homes with support from a facilitator. So they could then choose to use either the printed materials, the digital platform, or a combination of both, depending on what suited them best. So the aim of this feasibility study was not only to see whether the program could be delivered successfully, but also whether patients could engage with it and whether we could see a positive signal in patient-reported outcomes. So to evaluate this, we measured quality of life, self-care, health status, and psychological well-being before and after attending the program, and again in line with the UK REACH trials. So what did the program actually look like? So the program was built around 4 main resources. It was a patient handbook, it was a progress tracker, it was a handbook for caregivers, and then it was this digital version of the program available through the national platform called My Life, My Health, in Danish, Mit Liv, Min Sundhed, which is a common used digital platform here in the Danish healthcare system. So again, the overall aim was the same as conventional cardiac rehabilitation, to help patients better understand and manage their heart failure. And over the 12-week program, participants worked through different topics together with a trained facilitator. And these included topics as understanding heart failure, symptom monitoring, self-care, physical activity, and psychological well-being or emotional well-being. And of course, physical activity was a key part of the program. And depending on the participants' abilities and preferences, and again in line with the UK, participants could follow a chair-based exercise program, a progressive walking program, or in the perfect world, a combination of both. So the digital platform contained the same core content as the printed materials, but it also included, for example, exercise videos, mindfulness exercises, and so on. So importantly, the program was not delivered in exactly the same way to everyone. It had this person-centered approach where the facilitator worked together with each participant to set individual goals and adapt the program to their needs and daily life. And again, some participants preferred using the printed materials, some mainly used the digital platform, and many actually chose a combination of both. So who participated in the trial? Yeah, we included 71 patients with heart failure and reduced ejection fraction. The mean age was 75 years and around 2/3 were men, and the mean ejection fraction was 30%. Most participants had symptomatic heart failure and were also receiving guideline-directed medical therapy, and almost 70% were living with 3 or more comorbidities. So overall, this was an older population with many comorbidities, and maybe also in many ways, these are the patients who often struggle to participate in conventional center-based cardiac rehabilitation. So how about the patient-reported outcomes? So we observed improvements across several patient-reported outcomes. Our primary outcome was disease-specific quality of life, measured using the Minnesota Living with Heart Failure questionnaire, again in line and the same used in the UK. So the mean score improved by just over 8 points, and this improvement was statistically significant and maybe more importantly meaningful for patients, because in people with heart failure an improvement of 5 points or more is considered enough for patients to notice a real difference in their everyday life. We also saw improvements in general health status, in depressive symptoms, and also in self-care. So overall, this suggests that the participants benefited from the program, and in many ways, not just in one specific outcome. And perhaps just as importantly, our findings were very similar to those reported in the original UK REACH trials, which of course gave us confidence that the program can be successfully adapted to a Danish healthcare setting, while of course maintaining the core components and its intended benefits from the original REACH. So so far I've talked a lot about the program as a whole. So now I would like to focus on the digital platform due to the topic for today. So overall, we were actually pleased to see that most participants accepted the digital program. In fact, almost 80% chose to use it, while around 1 in 5 preferred to use only the printed materials. So for those who used the platform, many participants expressed that they appreciated the flexibility. They could assess the program whenever it suited them. They could watch the exercise videos. They could revisit the educational materials, and they could combine the digital resources with the printed materials. So as we expected, we also experienced some challenges with the digital part of the program. So among the participants who used the app, 18 reported at least one app-related challenge. So we evaluated app-related challenge by asking at each follow-up if the participants had experienced a challenge. And if participants then reported a challenge, we asked 3 follow-up questions. We asked whether they found the instructions confusing, whether they experienced technical problems, and whether they still felt motivated to continue using the digital part of the program. And here, technical problems were by far the most common issue, while motivation generally, luckily, remained high. So to sum up, I would like to leave you here with 3 key messages from the DK Reach trial. So first, we showed that the program was feasible. We had good recruitment, we had high retention, and participants remained engaged throughout the program. We only had 5 dropouts where 4 were due to death. Second, we saw a positive clinical signal. Participants reported improvements in quality of life and self-care, and the results were consistent with previous REACH HF trials from the UK. Finally, we believe that this program has the potential to improve access to cardiac rehabilitation in Denmark. Home-based rehabilitation with flexible delivery options can help improve access to cardiac rehabilitation, maybe especially for patients who do not participate in conventional center-based programs, the so-called hard-to-reach group. So this was my last slide. So thank you for your attention, and I will of course be happy to take any questions or comments after the 2 next sessions.
Thank you, Malene, for this wonderful presentation. Beautiful. So our next speaker is Kaitlyn Young and Kaileigh McGill. So please, if you can share your screen and share your thoughts with us.
No problem. Just let me share my screen. Let me just get that up there. Is that seen all right?
Yes, please.
Fabulous. Well, Malene, I'm glad to hear that everything's going well with the Danish project. I think we had met during your training for REACH HF, so that's lovely. I'm glad to hear the updates. And thank you guys so much for inviting us to speak a little bit about the digital heart manual. My name's Kaitlyn. I'm the physiotherapist here at the Heart Manual Department, and Kayleigh, my colleague, will be taking over in about 5 minutes. I'm going to give a little whistle-stop tour of the digital heart manual just to give you a brief overview, and then she is going to take you through what it looks like as a resource. So, as most of us are aware in the room, the Heart Manual itself is a home-based cardiac rehabilitation program, and it's anchored in these principles of self-management and health behavior change. There are 2 editions of the Heart Manual that exists. There's one for patients that are recovering from a myocardial infarction, the post-MI version, and there's also another for patients that are recovering from a revascularization, whether that be a bypass, balloon, stent. With over 30 years of experience and evidence, the Heart Manual is an intervention that is delivered by trained registered healthcare professionals. They come along to a 2-day course, and it is continuously, as a resource, maintained and updated by our team to reflect the current evidence-based practices here in the UK and internationally. Now, because of the abundance in evidence of the Heart Manual, it is included in international guidelines, national guidelines for cardiac rehabilitation, and it has proven to improve the reach of service, the reduction of barriers to traditional center-based rehabilitation. The program itself includes many interactive features, progress tracking, relaxation audio, and individualized walking and aerobic-based and strength-based exercise programs. Now, the digital heart manual is exactly the same as a traditional paper-based manual. It has the same fundamental architecture as the original program. The only difference is that's online. It's on a digital platform that can be accessed through smartphone, through tablet, through computer. It contains all the same interactive features as a traditional heart manual, and it was collaboratively developed with our public involvement group, which consists of patients, practitioners, and e-health experts. Now, as with the heart manual, the paper version, the digital manual is a 6-week structured program based on the ideas of self-management and risk modification. Now, the program was designed to be very flexible in its initiation, meaning that it is safe and valid to start from early rehabilitation, the inpatient phase, and has been validated all the way throughout the outpatient phase of cardiac rehab, or what we call in the UK core cardiac rehabilitation. Ideally, the program should be initiated early. This will help with streamlined care. This helps early identification of misconceptions and helps to promote adherence to rehabilitation. But that being said, obviously there's precautions and tailoring that might need to be required for certain patients and procedures. For instance, thinking about exercise modification for patients that have sternotomies or more invasive surgeries. Now, the program, as I said, is facilitated by trained registered professionals, and it is holistic in nature, meaning that it does hit on all of these different cardiac risk factor modifications, same as traditional cardiac rehabilitation. Now, I won't go into this in too much detail because I know Kayleigh is going to run through this with yourselves, but essentially the components of the digital heart manual are exactly the same as those of the traditional manual. The only difference between the revascularization version and the post-MI version happens in part 1. So this is where the story kind of changes. For post-MI, the heart facts start predominantly with having a heart attack, whereas in the revascularization version, we talk a little bit more about the interventions, the PCIs, the revascularization, the CABGs. And we do this just so that we don't overboard the patient with too much information about something that isn't potentially relevant to themselves. Part 2 is the weekly program. So as opposed to REACH, it is just a 6-week program, and each week we have a different risk factor that we focus on. And throughout those weeks, we have daily relaxation audio, walking programs, and a progressive aerobic and strength-based exercise videos and activity logs. Part 3 of the manual is again the same for both post-MI and revascularization, and this talks a lot more about the other aspects of recovering from a heart condition. So it includes things like medical management, emergency procedures, getting back to work, managing social life, just different aspects that we would cover in cardiac rehabilitation. Now, the heart manual itself has over 30 years of evidence in supporting the use for post-MI and revascularization patients, and the digital format has been proven to have high support for patient engagement and accessibility with our users. Healthcare providers have reported improved patient adherence to the program and reported time saving in program delivery and patient follow-up, which is increasingly important with a large caseload. So recently, the digital heart manual has been included in the NICE early evaluation assessment for digital cardiac rehabilitation, and we are working alongside the National Audit for Cardiac Rehabilitation down in York in the UK to generate some real-world evidence to support the digital heart manual's use in cardiac rehab. And currently, our early findings are indicating high levels of adherence to the program, medical compliance, improved functional capacity tests, and improvements in anxiety and depression scores. So that is just a quick whistle-stop tour of that. And I'm going to stop sharing my screen and hand over to Kayleigh, who's going to run through the program with you in a bit more detail.
Thank you, Kaitlyn. So I'm just going to share my screen. And hopefully you can all see that okay. Does that all look okay? So, hi everyone. Thank you for inviting us along to speak today. So, Kaitlyn has provided you with the background and the evidence base, which is supporting our digital heart manual and its development. But we thought it would be a nice idea to take you through the programme, show you how it all works, and point out some of the key components and resources. So this is our digital heart manual website here. And as you can see, this is the post-AMI version. And as Kaitlyn has mentioned, there is a separate website for our REVASC version. But in terms of the usability and the layout, they both work in exactly the same way. So down the left-hand side of the screen here, this is where all of the main programme components are located. So you can see here there's the three main parts, so part 1, 2 and 3. And as Kaitlyn has mentioned, part 2 is where patients can work through each of the 6 weeks of the programme. Now down the right-hand side of the screen here, this is where some of the key resources are located. So through our previous evaluations, we found that these resources were either ones which patients engage with most frequently, or ones that they felt were most useful. So they're located here for ease of access, and so patients don't necessarily have to go through all of the main components to find the resource that they're looking for. So I'm just going to take you through the main components, and again, just point out some of the key resources and components of the programme. So when patients log into our digital heart manual, they'll be automatically on the homepage here. Now this just provides patients with a general overview into the programme and the type of guidance that's provided. And then similarly on the About page, this goes into more detail on the history of the heart manual. And you'll see at the bottom here, there is a link to our website, so they can really get a feel for what the heart manual is and what we do here as a department. And then you'll see the How to Use tab. So you have the How to Use This Manual section and the How to Use This Website section. So if I just show you the How to Use This Manual section, this breaks down each of the key or the 3 main parts of the programme. And you'll see here patients are also provided with some Q&A audios. Now this just provides them with some factual information towards their condition and their recovery. And this is just quite a nice resource for patients who are just starting out on the programme and who may be finding all of the written information a little bit overwhelming. So this is just a nice way to kind of ease them into the programme and get them started. And you'll see there's an audio for patients, and there's also a separate audio for their friends and family to access as well. Now, I know we previously said that the paper manuals and the digital manuals are both exactly the same, but the How to Use This Website section is the only section that differs between both versions. And this is just about providing patients with a little video tutorial on how to navigate the website, just like I'm doing at the moment. And there's also just some technical support links should they have any problems with their browser or accessing any of the downloadable content from the manual itself. So I think that really sums up all of the introductory content that patients are provided as they begin engaging with the programme. So now I'm just going to run through the 3 main parts. I know we don't have a lot of time today, but I just want to point out some of the key components of our heart manual programme. So within week 1, the key focus within this, part 1, the key focus within this part is really providing patients with in-depth information about their condition and their recovery. And you'll see this provides patients with information on what a heart attack is, what caused their heart attack, and it's really just about providing patients with information towards the recovery process and what that may look like for them. And then part 2, as we said, is where patients can work through each of the 6 weeks of the programme. So within week 1, as well as providing patients with loads of information which addresses some common questions, concerns, misconceptions that they often have at this stage in their recovery, one of the main focuses is getting them to really understand the importance of physical activity and supporting their recovery. So I just want to draw your attention to the exercise and activity plan page. So this is just about encouraging patients to start thinking about building their own walking and exercise plans as they move through the programme. So you'll see these 3 links here. So the first link is providing them with some guidance and advice on how to start building their walking plans. The second link here provides them with some visual examples of some recommended stretches, aerobic and strength exercises that they can then begin incorporating within their own exercise plans. And also patients will be provided with our at-home exercise plan video, which just shows all of these recommended exercises in practice within their home environment, which they can then start engaging with. And also, in addition to introducing the importance of physical activity and supporting recovery, patients are also introduced to relaxation. And week 1 is also where they can begin to access all of our heart manual relaxation audios. So you can see here there's audios in relation to different relaxation techniques, correct breathing techniques, visualization practices. So then if we move into week 2, again, they're building upon their exercise and activity plans. They can again access the relaxation materials. And from week 2 onwards, there's a different risk factor that's focused upon. So you can see within week 2, this is smoking. In week 2, patients can also access this really nice case study, which provides an example of a patient who's in a similar situation to patients and really kind of highlights how a patient has used all of the key guidance and resources provided by the programme to support their own recovery. And this is just a nice way of building that peer support and confidence in how the programme has helped support another patient's recovery. And then you'll see at the end of week 2, there's also a little quiz, which is a nice way to kind of address common misconceptions and really test their knowledge so far. They can complete this as many times as they want. They can save, they can check their answers, and just really see how their knowledge is progressing. Week 3 and 4, there's some really similar components that are covered, which the key focus within both of these weeks are stress and stress management. And you'll see within week 3, the risk factor focused on is diet, and week 4 it is being overweight. A key focus of week 5 is really getting patients to think about how or reflect upon how their exercise and activity plans have been going so far. So if they're managing to meet the goals they're setting out for themselves, they're really asked to consider, well, what else can I do to make sure I'm still progressing in my recovery and supporting my recovery? So can I walk at a steeper incline, for example? Can I walk a longer distance? If they are not managing to meet the goals they're setting out for themselves, they're really asked to consider, well, what can I do to make these goals more attainable? And you'll see within week 5, there are more anti-stress tactics, and there's a focus on lack of exercise as a risk factor as well. And lastly, week 6 is really about bringing everything together and really reassuring patients that whatever stage of recovery they find themselves in at the end of the programme, they're still benefiting from engaging with the programme. There's also a focus on the risk factor of high blood pressure, dealing with hostility and anger. And I also just want to draw your attention to the week 6 checklist as well. Now, this is just quite a nice resource at the end of the programme for patients to tick off everything they've learned, all the behaviours they've engaged with, to really see how much they've progressed. And it's also quite nice for goal setting and action planning as they're nearing the end of the programme to really reflect on areas that they still want to work in and areas they can still work in to support their recovery. And then lastly, part 3, as Kaitlyn had mentioned, this just provides more information into loads of different components of recovery. So there's types of medication, medication adherence, dealing with anxiety, sleep problems, pain, and loads of different recovery components. And then, as I mentioned, just before I finish up today, on the right-hand side is where some of our key programmes and resources are. So you'll see here, there's the contents page, which provides patients direct links to all of the main manual sections. You can see they can access the home exercise plan here, the relaxation audios. And I also just want to show you how patients can engage with the walking exercise and activity records on our digital manual. So you can see they can fill in these records for each of the 6 weeks. And if I just show you how this works. So they can pop in the date, they can record their walking goal for that particular day, and then they can report the level of difficulty they found this to achieve. They can add it to their record, and then they can view all of their previous entries. And the exercise record does work in a similar way. So again, they can pop in the date, the length of exercise, how many times they've engaged with a particular exercise, again, the level of difficulty, and then the exercise record also allows them to provide themselves with additional notes. And again, they can refer back to any of the entries that have been made. And then the activity record is for any extra activities in addition to walking and exercise that they feel has really supported them in their recovery during a particular week. So some of the examples here are phoning a friend, going to the shops, for example. They can pop in the date and leave themselves little notes as well. And then lastly, the patient questionnaire section. So there is a questionnaire for patients to complete before they engage with the programme and then after programme completion. And this just allows us to gain an insight into how well the programme was able to support key components of a patient's recovery, and also gain insight into their views towards all of the components of the programme. And this is just a really nice resource for us as a department to have, to really make sure we're continuing to adapt and evaluate the programme, and ensure that the programme is continuously able to meet the needs of patients. And one nice little feature that I do want to draw your attention to before I finish up today is our ReachDeck accessibility tool that is built into the digital manuals. And you can access this by clicking on the little icon in the right corner here. And this tailors our digital manual to meet the specific needs of patients. So some examples of what ReachDeck can do is it can read text aloud, it can convert text into a visual format, it can change the colour of the text itself and the background of the digital manual to make the manual more user-friendly for patients with dyslexia, for example. And yeah, just really tailors the digital manual to meet specific needs of patients. So that is our digital heart manual intervention, and hopefully you can see that it just provides, it's really intuitive to use, it's really easy to navigate, and it does provide a really nice alternative to our paper-based heart manual programme. And later on, we're happy to take any questions you may have about the heart manual. Thank you.
Thank you so much for this insightful presentation. Now we have our last presentation of Dr. Samantha Van Buerden. Please, if we can play it. Thank you.
Thanks, Bilal. Just give me a second while I tee this up.
Yep, sure.
Hold on just a little second.
Really pleased to share some reflections from our work on DV. Hi, I'm Sam Van Buerden, a Senior Research Fellow at the University of Exeter Medical School. Thank you for inviting me to contribute to the Across Digital Cardiac Rehab seminar. I'm sorry I cannot join live, but I'm really pleased to share some reflections from our work on DVHF. I understand this session is intended to inform across thinking around digital cardiac rehab, including Bilal's PhD work on the development and evaluation of digital support for the across adapted home-based cardiac rehab interventions. I'm not assuming that DVHF is the right digital approach for across, nor that something entirely new needs to be developed. Instead, I'm presenting DVHF as one worked example of digital cardiac rehab development, optimization, and adaptation that may inform across decision making. So I'll focus on what we built, how we developed it and evaluated it, what seemed to work, what remained difficult, and what we then learned for cultural adaptation work to South Asian communities. I'll start with the wider challenge that DVHF was trying to respond to. The starting point is that cardiac rehab is evidence-based, but access and engagement remain major challenges. For people living with heart failure, participation in cardiac rehab remains low. The challenge is therefore not simply whether rehab works, but whether people know about it, are offered it, are supported to start, engage with it, and complete it. This matters for digital cardiac rehab because digital support will only be useful if it helps within this wider pathway. It might support education, self-monitoring, motivation, family involvement, facilitated delivery, data capture, or longer-term maintenance, but it will not automatically solve problems of awareness, referral, trust, literacy, access, or engagement. So one of the key questions for any digital approach is, where in this pathway is it intended to help? And what problem is it actually trying to solve? With that in mind, I'll briefly introduce DVHF. DVHF is a digitally adapted version of the ReachHF home-based cardiac rehab program for people living with heart failure. It is not a standalone app, and it's not simply a digital manual. It is better understood as a blended digital and human facilitated intervention. There are three linked user interfaces. The patient view gives access to education, exercise videos, self-monitoring and progress tracking. Then there's a caregiver or family view support, which supports involvement by giving access to education for the caregiver and, where invited, insight into the patient's progress. The facilitator or healthcare professional view enables staff to see patient-entered data and use that information to tailor their support during follow-up session calls. That is important because DREACH-HF was designed to support and enhance facilitated home-based rehab, not replace the human support that sits at the center of REACH-HF. To understand what was being adapted, it is helpful to briefly revisit the original REACH-HF intervention. As you all likely know already, REACH-HF is a home-based rehab program for people living with heart failure. It includes several key ingredients: home-based delivery, facilitated by a trained health professional, regular exercise, stress management, symptom monitoring, medication adherence, and active caregiver involvement. These are not just pieces of content. They represent intervention functions. The program is trying to support self-management, build confidence, encourage safe physical activity, help people monitor symptoms for appropriate early help seeking to avoid hospitalization, support medication adherence for optimal patient benefits, and involve caregivers to support the patient and look after their own well-being where appropriate. So when we developed DREACH-HF, the task was not simply to put REACH-HF materials onto a screen. The task was to preserve these core functions while changing the delivery format and support model. That is relevant across decision making because any digital option needs to be considered in relation to the functions that it is supported or expected to support within the adapted home-based rehab program. The next step for us was to co-develop and optimize the digital version. DREACH-HF was developed using the person-based approach. That meant involving patients, caregivers, and healthcare professionals throughout the development process, rather than designing the platform first and asking for feedback at the end. The process included patient and public involvement, early prototyping together, thin cloud interviews, iterative refinement, and feasibility testing. The thin cloud work was particularly useful for digital development because it allowed us to see how people actually responded to the platform or the iterations of the platform that we had. We could explore whether navigation made sense, whether wording was clear, whether icons were understood, whether the self-monitoring tools felt useful, and how the platform might support or disrupt facilitation. So development was not only a technical design task, it required iterative work with the people who would use it, support it, introduce it, and ultimately deliver the intervention. One of the lessons was that digital adaptation slightly changed the delivery model. Digital adaptation changed more than the format of REACH-HF. In the original paper-based version, patients used manuals and offline tracking, and facilitators often relied on patients' retrospective accounts during consultations. In DREACH-HF, content was delivered through a digital platform, self-monitoring could be entered and reviewed, and facilitators could view patient-entered data remotely. Caregiver involvement could also be supported through a caregiver view. That changed what was visible, when it was visible, and how support then could be tailored. This created new opportunities. For example, facilitators could prepare for consultations using patient-entered data, and patients could see their progress more clearly. But it also created new requirements: onboarding, digital confidence, usability issues, data boundaries, technical support, and workflow integration. So digital adaptation is not neutral in a way. It changes how patient caregivers and healthcare professionals interact with the intervention itself. So what seemed to work in the early DREACH-HF work? Overall, the early DREACH-HF work suggested that the platform was acceptable and feasible. We conducted interviews with patients, caregivers, and healthcare professionals after they had received or delivered DREACH-HF. Participants valued being able to access rehab from home and engage with information in their own time. Self-monitoring helped people build routines around exercise, symptoms, weight, medications, and well-being, and facilitator support really remains central here. Patients and caregivers valued knowing that someone could see their progress during the facilitated period. Facilitators also felt that the dashboard helped them prepare for consultations and tailor their support more efficiently during follow-up sessions or calls. Another important signal was that patients wanted continued access to the platform after the facilitated program ended, despite knowing that no one would be looking at their data. That suggested perceived value as an ongoing self-management resource. So the potential value of digital support was not only about delivering content, it was also about supporting routine building, facilitated tailoring, caregiver involvement, and ongoing self-management. At the same time, the work also highlights several challenges. The platform was acceptable and feasible, but it was not easy for everyone or simple for some services to deliver. Onboarding really mattered. By this, I mean the initial steps of getting set up, logging in, understanding where to go, and feeling confident enough to start using the platform. Passwords, setup, and initial navigation could become barriers. Digital confidence varied across our participants, even among people who owned and regularly used digital devices. There were also technical and usability issues, and engagement varied over time. So some of these barriers were not specific to digital delivery, though. Health setbacks, low mood, comorbidities, competing responsibilities, and caregiver burden can all affect engagement with cardiac rehab in any format, whether paper-based, center-based, home-based, or digital. What digital delivery can do is make some of these challenges more visible or introduce additional points of friction, such as logging in, entering data, understanding icons, or knowing who is monitoring the information. From the service perspective, workflow fit is really important. If a digital tool does not fit with how staff document care, communicate with patients, and organize follow-up, it risks becoming an extra burden. So one of the main lessons was that digital access is not binary. It is not simply a question of whether or not someone has a device or internet connection. Digital access also includes whether people feel confident using a platform, whether design is accessible, whether support is available, whether family members can help if needed, whether data entry feels manageable and relevant, and whether the digital tool fits into everyday life. Similarly, service access is not binary either. A service may be interested in digital cardiac rehab, but still need training, workflow, alignment, technical support, and clear boundaries around monitoring and follow-up. These early findings, alongside the wider evidence underpinning REACH-HF, then fed into a national assessment of digital cardiac rehab. And this has been particularly exciting. So this slide is about NICE's Early Value Assessment, or EVA. For colleagues outside the UK, NICE is the National Institute for Health and Care Excellence, which provides evidence-based guidance for health and care in England. The EVA process is used for promising technologies where early use may be appropriate, but further evidence is still needed. For DREACH-HF, the evidence from the original REACH-HF program, alongside the early DREACH-HF development and feasibility work, contributed to the NICE EVA signal that has resulted in a conditional recommendation for early use in the NHS of DREACH-HF. That conditional recommendation is now linked to an evidence generation period. So the next phase for DREACH-HF is about answering questions such as which services can deliver it, which patients are offered it, who starts, who engages, what support staff and services need to deliver, what data are needed to be able to evaluate this properly, and how do we avoid widening inequalities further. So NICE EVA is not the end of the evidence journey. It creates a structured opportunity to generate further evidence about digital cardiac rehab in real-world NHS settings. Alongside this, a wider program of work is also focused on cultural adaptation, particularly with a group underserved by cardiac rehab. So the early DREACH-HF work was really promising and exciting, but it also had an important limitation. The people involved in the development and feasibility work were not sufficiently diverse. This was also the case for the underpinning REACH-HF development and evaluation work. That meant we could not assume that the original program or the digital version will be equally relevant, accessible, or engaging for underserved communities. Digital feasibility does not automatically mean equitable access. A platform may work well for one group while still failing to address language, culture, trust, family roles, digital access, literacy, or service pathways for others. So this led to further work, culturally adapting DVHF for and with British South Asian communities. For across, this is particularly relevant. Our British South Asian adaptation work may not be directly transferable to Bangladesh, Pakistan, or India, but the underlying lesson is important. Cultural adaptation needs to consider the whole path into and through rehab, not just the content or the interface. In practice, that meant for us, the adaptation process became much more relationship-based. In our cultural adaptation work, we wanted to work with people not only underserved by health services, but also very much underrepresented in the research underpinning those services. We worked with patients, caregivers, community partners, and healthcare professionals from British South Asian backgrounds. The community partners, including DECPAL and South Asian Health Action, were important because they brought trusted relationships and contextual understanding that academic and clinical teams do not automatically have. The work did consider language and cultural relevance, but it was not mainly about translating written materials. In fact, one of the issues we discussed with our community partners was that written text itself can be a massive barrier. So rather than simply translating written content, we worked with our community partners and our patient involvement group to develop video scripts and creating videos around key parts of the program that they were particularly interested in. So delivering content in a much more accessible format. We also looked earlier in the cardiac rehab pathway, including eligibility, offer, explanation, and the way the program is introduced. This is important because some barriers can arise before someone even starts the program. For example, staff may unintentionally make assumptions about whether someone would want to take part, whether they would be able to use a digital or home-based program, or whether family involvement would be appropriate. So part of the adaptation work was about recommendations for facilitator training, how facilitators can be culturally aware, how they can introduce and adapt delivery appropriately, and how they can involve families in a suitable way, and how they can avoid making assumptions about people's preferences, needs, or family roles. This training is available in the facilitator interface of DVHF platform as well. So one of the strongest lessons was that cultural adaptation isn't just about language. It is about format, relationships, family context, service pathways, digital confidence, facilitator practice, and whether the intervention feels relevant and meaningful in people's lives. This kind of learning may be useful to across decision making, regardless of whether future digital support involves an existing intervention, selected components of an existing intervention, or something completely newly developed. One of the clearest messages from this work that we've done was that access starts much earlier than use of the platform itself. For a digital intervention, it is easy to just focus on whether someone can use the platform or not. But access begins much earlier than using the platform. It begins with awareness, explanation, eligibility, offer, and trust. Trust is especially important because it runs throughout the whole pathway. It is not only about whether someone trusts the technology, it is also about whether they trust the program itself, the evidence behind it, and the person introducing it and supporting them. Some of our adaptation work therefore focused on how the platform could support building that trust. For example, we developed videos together to explain key parts of the program and the evidence base for DVHF in a more accessible way. We also developed videos to explain how the facilitator would work with the patient, including that facilitators are trained health professionals, such as nurses, physiotherapists, or other cardiac rehab staff, who are actually trained also to deliver this particular intervention. But trust is not built by information alone. It is built through relational work that the facilitator does as well. Listening carefully, hearing voices that are often not heard, and adapting support to the patient's needs and preferences. Family context in this case is part of that as well. There can sometimes be assumptions that for South Asian patients, family members will naturally be available or expected to support rehabilitation. But family situations vary, and British South Asian families may be navigating different cultures, expectations, and relationships within the same household. So the facilitator training also focuses on identifying what kind of family support is wanted, appropriate, and acceptable for each patient. That matters because involving family in the wrong way or against the patient's wishes could damage trust rather than build it. So digital and cultural adaptation need to address the whole pathway into and through rehab, not just the digital interface. As such, this means that a whole system approach is needed. For DVHF, the digital platform was only one part of the intervention. It sat alongside trained facilitator support, patient education, behavior change, self-monitoring, exercise, caregiver involvement, service workflows, and decisions about how the program is offered and introduced. So when we think about digital adaptation, the question is not only whether the platform works, it is whether the digital tool fits and can support the wider rehabilitation system around it. For across decision making, this raises a very practical question. What role, if any, should digital support play within the wider adapted rehab system? It might support patient education, self-monitoring, facilitated delivery, family involvement, data capture, and so on. Depending on the system this is to be used in and the people who are meant to use it, each of those functions could lead to different design choices, adaptation needs, and evaluation questions. To close, I would frame the learning from DVHF around these building blocks towards effective adaptation. First, core program functions need to be retained. Adaptation should not lose sight of what the original intervention is trying to achieve. Second, content may need to be tailored for language, culture, literacy, and relevance. Third, format really matters. Delivery mode, interface, and usability shape access and engagement. Fourth, support matters too. Human and digital support can build confidence, capability, and continuity. Fifth, relationships are crucial. Trusting relationships may enable uptake, engagement, and shared decision making. And finally, implementation conditions. Workflows, resources, training, and context shape where the delivery is feasible. So taken together, these building blocks suggest that adaptation is not just changing content. It is about preserving the intended functions of rehab while redesigning how it fits people, families, services, and their settings. I would warmly welcome any questions or reflections, either by email or shared with me through Rod. I'd also be very happy to discuss possible areas of learning or collaboration around DVHF, particularly where it may be useful for future digital cardiac rehab work. I'm sorry I cannot join the discussion live, but I look forward to hearing any thoughts from the Across team and partners. Thank you very much for listening.
Thank you so much to all of our speakers. So if we have any questions now. Professor, you are mute, please unmute yourself.
Sorry about that. I was just saying 3 really excellent presentations, Bilal. Very, very stimulating discussion. So again, just to encourage you, I don't see any comments in the chat, but if you would like to raise a question, and please would, if this, encourage you to do so, please put your hand up, either your real hand or your virtual hand, and we'll hand over to you. And maybe you can unmute yourself, give a brief introduction, and then ask your question. So Jamal, I think we see your hand up, so maybe we'll hand over to you first. Thank you.
Yeah, thank you so much. Can you hear me?
Yeah, you're a little bit quiet, Jamal, so please do speak up. Thanks.
Okay. So my question to first presenter from Denmark. So I am the Jamaluddin and project country manager. Excellent presentations. Can you hear me now?
Yeah, now I can hear you.
That's great. Thank you so much. So I am Jamaluddin from Bangladesh. I am a country project manager across project, and thanks for your nice presentations. So I have a very good connection in Denmark. That in 2014 I was in Denmark and work in Riis Hospitalet and also in the commune hospitals in Holbæk. So, however, as I saw your presentation, that approximate 50% patients has been referred for cardiac rehab. But as I have seen that where Denmark, there is a very nice connecting referral system over Denmark. Just my question is, why the percentage of referral is not so high, not just for 50%? This is the first question from my side. And second one, that you have found out the feasibility trial that where patient-reported outcomes you checked, like Minnesota Living, EQ5D, and so on. But did you collect any kind of biomarkers? Related outcomes like medical report outcomes like this. If you have, what are the results? If you have any collections. And I see that the acceptability and feasibility, the recruitment is fine, excellent. So this is one questions to you. Yeah, thank you so much.
Yeah, thank you, Jamal, for your question. Yeah, thank you for your fine words. About referral, we ask ourselves here in Denmark, why is it higher? So one of my projects in our PhD is actually to explore why with the clinicians' barriers, why are we not good enough to refer patients, even though you worked in Denmark, so free of charge and publicly funded. So we will explore that in my PhD as well. So yeah, and for the second, was that answer enough? Yeah. We know that you can divide barriers to participate in rehabilitation at three levels. So there is the clinician barriers. We explore that by translating and validating a questionnaire and have a lot of data on that. Then there is this patient barriers where we try to offer a different alternative as the home-based cardiac rehabilitation program. And then there's the third, which is called the system barrier, which we will not explore in my PhD. So hopefully we have some answers about the referral rate in Denmark later on. So about the biomarkers in our feasibility study, we did not collect any biomarkers. So we collected also serious adverse events in the trial and found that, of course, some patients, but it was only admissions, and we divided admissions due to heart failure, due to other, and then deaths. So that was the more hardcore outcomes. Our primary outcome is quality of life measured in the Minnesota Living with Heart Failure.
Thank you. Thank you so much.
Yeah.
Thanks, Jamal. Thanks, Malene. So I think we've got another two hands up. So Mosheen first and then Amy Blackmore. So Mosheen, would you like to unmute yourself, introduce yourself and ask your question, please? Thank you.
Thank you so much. This is Mohsin Alvi and my area of work is health economics. I am from Pakistan. First of all, excellent presentation. All the presentations were very informative and very good. My question is from the first presenter, that is Malene. It was very interesting presentation, and I was looking at the EQ5D value. So the utility value were same at the baseline and the follow-up, but the VAS visual analog scale, that value increases. So this is very interesting finding. So did you get a chance to go for any supplementary analysis or complementary analysis? Is this something like a ceiling effect? Means they already have a high utility value, we can see that 0.8, or did you get chance to look at what will be the reason of this? Because VAS increasing, but utility is not increasing.
Yeah, thank you for your question. So yeah, you're right, and I haven't been analyzing more into those results, but maybe I will after these questions, because yeah, as you mentioned, the utility score increases, but yeah, the other doesn't. So, but maybe in the future I'll do that. Yeah, thank you.
Thank you. And just a follow-up of this question answer, that what value sets you use for this analysis? Which country value set?
Sorry?
And we have a value set for EQ5D, right?
Yeah.
For the different countries. So which country value set you use for this analysis?
Oh, sorry, I can't remember. It's the one they recommended, and yeah, maybe I can't remember exactly the. Do you know that, Rod?
So maybe I can help. So it's a great question, Mohsin. So I think we ended up using, but we need to double check these. These are really interesting questions from Mohsin. I think we used the UK valuation set, Mohsin, rather than the Danish, but that's something we need to check, Malene. And another thing we might want to do is see if we could then, if we haven't applied the Danish population values, we should do so, because there is some evidence that different countries value the questions in the five questions of the EQ5D slightly differently. But Mohsin, the great thing is that Malene's coming to Glasgow in October. We've got the individual patient data. So one of the things we can look at is that association between the index score and the VAS, because I noted, like you, one was sensitive, but the other wasn't. And why is that? So maybe that's something we could look at your data a little bit more, Malene, because it's certainly a question that a health economist would ask us, such as Mohsin. Yeah.
Thank you very much. Thank you.
Thanks very much. So, Amy, I think you're next. Please introduce yourself and ask your question. Thanks.
Hi, my question's also for you, Malene. Sorry about that. It was just really interesting presentation. And I'm particularly interested in the psychological impact of the intervention. And I noticed that you reported a good, significant reduction in depression scores, but not in anxiety. And I wondered if there was any kind of process evaluation or insight into why that might be with the anxiety, and things that perhaps could be improved to increase that impact.
Yeah, so thank you for that, Amy, and thank you for all your questions here. I will practice my English now. But yeah, so, again, we haven't gone any deeper to those results. But I think for a heart failure population, maybe depressive symptoms are those where we can do some changes over time, and maybe not in the same level for anxiety. I think that is very similar to the heart failure population.
Okay.
But again, something we can go deeper in. We have a busy visit in Glasgow. Yeah.
Great, thank you, Malene.
And again, Amy, if I may, as you're aware, and as Malene mentioned, we've got a large randomized trial in patients with HFrEF. I think you might be part of the publication. I can't remember, but Jeff Lambert, one of our internal colleagues, looked at the question of, in the trial data set, are those people with the highest levels of depression and anxiety at baseline, do they get the most benefit from the intervention? And the answer is yes. So there does seem to be a relationship with the baseline score, and it may be that the Danes are slightly less anxious than the Brits. And maybe that might be one explanation. And we're certainly finding in our HFpEF trial, so this is an ongoing trial, we'll report later in the year, that we have very high levels of both depression and anxiety. So it will be particularly interesting there, Amy, to see whether we see equivalent treatment effects in both those groups.
Great, thanks, Rod.
Thank you. So conscious that we should be sharing out some questions in our other speakers. And by the way, your English is fantastic, Malene. It's better than mine. People understand you better than my Scottish accent. So maybe just a general question to our heart manual colleagues from Edinburgh, that it seems that one of the themes that's coming out from the three presentations is this idea that we don't just give a digital intervention, it still needs to be supported by a human. or a facilitator. So given that, I guess I have two questions for you, and maybe Malene, also you too. So one is, how comfortable do healthcare professionals feel using digital components? My sense is that they sometimes maybe aren't comfortable. And then the second one is, do we require, or have you required, technical support with these applications? So if they're happening live, do you need to have IT people in the background? And if so, what is your level of IT support ongoing that you've needed to put in place to make the digital interventions available? So maybe that's a question for Kayleigh and Kaitlyn in the first instance. Thank you.
Yeah, no worries. Kayleigh, do you want me to take this one? We'll popcorn this as much as we need to. Yes, so going through with regards to facilitators, whether or not they are comfortable with the digital resources, I think what's important is that from our perspective, so as a facilitator, I would still be using the phone. So even though the patient has the digital resource, the follow-up contacts are still kind of done the same as they would be whether the patient is doing a paper manual or whether they're doing a digital manual. The only difference is you could share a password and you could have the facilitator actually see what's going on progress-wise. From our department, we do quite a bit of updates, and Kayleigh lovingly does those with the facilitators. So there's lots of digital reboots to make sure, because we acknowledge this, you know, that it can be quite a learning curve to switch into a digital platform, even if the way that it looks is exactly the same as the paper manual. From our point of view, obviously we're NHS Lothian, so we still have our eHealth team supporting behind the scenes. And we are kind of always on that just in case. And we are the people that, if there's an issue that comes up from a facilitator, they can contact the department. So we're kind of always on hand if needed. But yeah, Kayleigh, is there anything that I've glossed over there or missed?
No, I think that's all covered. But I think what you saying that facilitators are sometimes less kind of confident with the digital manual, that sometimes that's what we find, but we do have our digital reboots, so they can come along and kind of ask any questions if there's any issues as they're facilitating it. But I think it's quite positive overall, I'd say.
Thank you. Great. And Malene, again, I'd be interested to hear how your experience was in Denmark with the healthcare professionals. Were they so willing to take on that part of the intervention also?
Yeah, as I mentioned, this digital platform is a common used, or should I say, have to use in Denmark, because many your medical records and so on for normal people, you have to assess it there. So I've not heard any challenges from the facilitators actually. So it's been more the participants, and so as we know, older people with many comorbidities and so on are the ones who struggle with the digital part of program. So in Denmark, you can, if you cannot access the digital platform, you can get a permission to have, for example, letters from the public publicity or hospital in printed materials, but then you so it is a common use, the digital app. So in relation to the facilitators, no, we did not experience problems.
Thank you, Malene. That's really helpful, because I think certainly, you know, and I think Sam's presentation implied this, that I think one of the barriers we've found with the digital version of Reach is sometimes not the patient, but actually the healthcare professionals and their comfort in accessing the materials, particularly, for instance, what we've tried to do in D-Reach is to give the facilitators access to the patient's ongoing diary, so that before they have a telephone call, Kaitlyn or Kayleigh or Malene, they can, if you like, study the patient's homework and know what issues they need to focus on. But let's just say that not every healthcare professional has been comfortable in doing that kind of activity. So whilst conceptually it's useful, these things can be practical barriers. Okay, back to the audience. So, Jamal, I see your hand's back up. Is this a new question?
Yeah, it's a new questions.
Go ahead.
To heart manual group, actually, first question is like, as in a different part of the world, in south part of the world, in Bangladesh, like where the physicians are the main first contact of the patients, and then after bypass surgery, the patients are more concerned to come to follow up to see his or her doctors, surgeons. And as you know, the bypass surgery patients, they have to, cut their vein or artery from their legs and or radial arteries from hand, and they need to have some kind of precautions. And as you know that your heart manual, where the exercise programs from week 1, 2, 3 in over there's a very similar exercise like stretching, strengthening, or like this exercise, but the precaution of the sternum and also the precaution for the vein where they grafted for cutting the vein to graft. So do you have any kind of experience that the patient feels any complaint or any complexity to come to the physicians and explain that they have some difficulties or complaints, and how did you manage this kind of complaint, if you have any experience? This is the first one. And the second one is this, the monitoring and evaluation for digital heart manual version. So how did you manage the continuous monitoring and evaluation of the patient's outcomes, or any kind of continuous managing, as we are going to looking forward to do heart manual and reach HF in Bangla version? So we need to know that continuous monitoring, how could you manage? Thank you so much.
No worries. Perfect. I'll take that, Kayleigh, if you want. So with regards to bypass patients, so in the UK, what we typically do for cardiac rehabilitation and for heart manual is the bypass patient, they'll receive their procedure and then they'll be discharged within 4 days. We don't typically start cardiac rehab at that point in time. So it would be more from a physical point of view, I should say. You can administer the heart manual program, you can stick with the education, you can talk a little bit more about the psychological well-being, but there's a lot of exercise things that you need to think about what like you said there. So for me specifically, it depends on when you're getting these patients. Typically, when we discharge a patient from the ward from a bypass, you would be expecting them to do some walking plan. But again, this is not necessarily a monitor of their cardiovascular fitness. It's more a monitor of their healing, as you were saying properly there, because you never know whether they had the bypass through, memories, or you had it through your leg. Regardless of that, the recovery is quite different. So from ourselves, the precautions are, you do have to think about within the first 6 weeks after a bypass. We typically wouldn't be doing the gradual kind of chair-based exercise program at that point in time as it is on the videos. You would be thinking about how you can monitor that and change that. So from our perspective, we do typically involve quite a bit of exercise physiology, quite a bit of physiotherapists to kind of individualize this plan. Typically what happens in the UK is you're not necessarily getting a bypass patient that soon after in terms of cardiac rehab. In an ideal world, you would get them immediately, but we know that that's not what's happened. We know that we get them usually 6, 8, 12 weeks after they've had a bypass. So at this point in time, absolutely fine to start with most of the exercises that are within the manual. Similarly, the heart manual is only a 6-week program, so the goal of that isn't necessarily to increase cardiovascular function or functional capacity. It's more to build confidence and motivation. So sorry if that's a little bit of word vomit there, Jamal, but essentially it is just about, we do have to monitor them and do what's safe for that patient at that point in time. From a continuous monitoring, and I do want to make sure I got this question as well. We have ongoing, in the UK, we use a national audit of cardiac rehabilitation, not in Scotland, I should say, just in other areas of the UK. So with this, what they do is they collate data with regards to our functional capacity testing for patients pre and post all cardiac rehab. So not just the heart manual, not just reach for every component. They do things like smoking status, they do things like BMI, and they look into different outcome measures psychologically, cardiac biomarkers, different types of things. So we can get this information ourselves as a department from the National Audit of Cardiac Rehabilitation. But for our patients, speaking as a clinician, typically I would see them as a cardiac rehab physiotherapist for about 12 weeks, and then they would be continuously followed up after that point from their GP, and they will be looking at different things with regards to their health status. And we can also refer them on to community settings for continued rehabilitation support, but that's usually how it goes. Sorry if that was a lot of talking. I've got the gift of the gab, so I'll stop there.
No, it's absolutely fine, and I think it's great that there is a different aspects of monitoring and evaluation by auditing and also individual as a clinicians. Thank you so much. And yes, you are right that we are focusing on this, that after bypass surgery we need to do some activities, but need to conscious about the healing process, need some time, and need to cautious about their sternum protection and also the grafting area. Yeah, thank you so much. Thank you.
Thanks, Jamal. And again, I think that's an important reminder. So Kaitlyn and Kayleigh and Malene, we're just about to start our pilot trial on Across, and we've got effectively 3 populations in there. So we've got post-MI patients who haven't been revascularized, we've got post-MI patients who have been revascularized, and we've also got heart failure patients. So I think the message you're saying, Kaitlyn, we need to think very carefully about the timing of when we introduce that rehabilitation after either that surgery or after diagnosis. And I think that's something we'll take away and reflect on very carefully, Jamal, as you were intimating with your question. So great. So maybe time for 2 more questions, and then Bilal and I will wrap up. So I can see one hand up. Matila, would you like to unmute, introduce yourself and ask your question, please? Hello.
Everyone, and thank you, the 3 beautiful girls, for nice presentations. And that was actually very interesting because as Rocktail, we are going to implement in our country. So I have only 2 questions, but that is how much actually digital intervention or digital rehabilitation program has effects on the cost effectiveness? Did you actually see that? Because if it reduces the cost of the rehabilitation and follow-up, then it is worthy. Another thing is maybe it's not in our country, but in Bangladesh, like this type of developing country, we have lots of issues with internet accessibility and availability. So is your app is working offline also once they have in the Play Store, or they have downloaded, the patients already downloaded? So offline online version is there, or only always working on online? So and that's what I want to know, because if we also do in the English version, I don't know that their understandability. Do we also need to actually do the digital app in Bengali version, because it's also is cumbersome, the language conversion in digital app, not in the manual books is fine, but that would be difficult. So do you have this type of suggestion to us?
Thanks, Matila. So maybe 2 questions for each of the groups. So first question is, can you use your intervention offline? So Malene, maybe come to you first on that one. Are you able to, do you have to have live internet access for you to use your digital component?
That's a really good question. Thank you, Matilda. And to be honest, I actually don't know. And so in Denmark, it was this hybrid study with the digital materials or the printed materials to maybe, So sorry, I can't answer, but I will see if
you can maybe find out for us and let us know, Malene.
I will. Yeah.
Yeah. Thanks. So Kaitlyn and Kayleigh, same question to you.
So for us, I think that the good thing about the Heart Manual Digital is that the exact same information exists in the book. So although it might not necessarily be I don't necessarily think you could access individual pages offline because of the way that the interface works there, but the exact same information in the same, pretty much the same layout as in the paper version. So if there was an issue with accessibility, there's genuinely no difference between the two, apart from the fact there's a digital platform. There's a few pages that you can download. I know that for sure. But I don't think as a interface you can do it offline.
Okay, so that might be an issue for us. And Mattila, sorry, your first question again, I've forgotten.
The cost effectiveness, if the
Cost
digital
effectiveness.
intervention, yes.
Yeah. So Malene, you collected costs, right? Are you able to comment on what is the cost of your intervention in a Danish setting?
And Mattila, if now I have the answer for your first question. You cannot attend the digital app if you don't have internet, because I just tried to do it on my own phone. So yeah, and as you the cost effective analysis, we did a light economic analysis, Rod and I and colleagues, and we actually saw that if you compared conventional rehabilitation with the REACH HF, it was the same price, so it was cost effective.
Yeah, and the cost per patient was about,
I think it was just under 3,000 Danish kroner, so that's in UK. Now I'm
about
not
350 pounds per patient.
Per patient.
That kind of level, Mattila.
Yes.
And Kaitlyn, Kayleigh, are you aware, has there been a formal cost effectiveness analysis done of the heart manual? I think
not the digital version.
Not the digital. Yeah.
Yeah.
But there has been a cost effectiveness analysis done of the heart manual, I think. I don't know if you want to comment on it. I know it was one of my colleagues was involved, Hayes Bilal. So I think when he looked at it, Mattila, they demonstrated that the heart manual was cost effective, but again in a UK setting. So of course we need to address that same question in the across setting as well. Yeah.
Yeah, definitely. Actually, digital app development and its cost, because it should be maintained all of the year round, whereby because you have some IT related and maintenance cost also. I think we can add this for our economic evaluation, not only for hospital based or follow-up, but also the digital intervention and maintenance. Yeah.
But I just want to add one thing, if
go ahead,
with your permission, like heart manual, there is a good option that the download options for full manual download options, and also individual the relaxations and also video parts. So I used this the version for my PhD part. So this is absolutely fine. I think it is an offline process. It is a cost effective for the patients. If we use, as Dr. Mithila said, this is really cost important for like country like Bangladesh. But if we use like a heart manual, the manual versions as well as the digital version with offline, they can use it. It's absolutely fine, and we can manage in our country also. Thank you.
Thank you, Jamal, for that clarification, because I think it's interesting, isn't it? Because maybe as we just come to a close, I mean, I think conceptually providing a digital opportunity for patients to choose how they might access these interventions makes a lot of sense. But as we heard from the three of you and also for Sam, it often comes down to very practical issues. And I think, you know, we are very much in the stage where we are currently adapting our interventions to the South Asian setting. So I think these will be very interesting questions that you've stimulated today in helping us think through how we might address this within the Across programme. So I'm going to suggest we finish up there. We've slightly gone over time, but sincere thanks on behalf of both.
Professor Rod, sorry, we have Professor Nusrat Hussain, and he raised his hand earlier. So if he want to end last thoughts, please.
Okay, Nusrat, you have the last word.
No, thank you very much, Bilal. You are so very kind. I'm going to reach out to all of you both with regard to the British South Asians, and also one of the things we are doing in Pakistan is delivering this intervention through primary care also in the pilot. So we'll get some thoughts from you. Thank you again. Okay. Excellent presentations.
Sorry I missed your hand. So just for your information, everybody, Professor Nusrat Hussain, who's Professor of Global Psychiatry at the University of Manchester and is one of our across colleagues. So it sounds like Nusrat will be in contact with you in due course. So I'm going to wrap up there just because we've run out of time. Thank you so much to our three speakers on behalf of both Bilal and myself. Yes?
Well, sorry to interrupt. Dilip has said, could we quickly get a very quick virtual group photo?
Ah, okay. So what
I have
you
to
need
stop
to do,
spotlighting you guys.
yeah, what you need to do is to put your camera on, everybody, and then we will take a virtual photograph somehow. Don't ask me, I'm not Gen Z.
Oh, that's Dilip's problem. He wanted it. He can take it.
Yeah.
Okay.
I'll take a screenshot. But unfortunately, I don't know why my camera's not working, so I'm on my
the irony
today.
is not working.
But yeah, that's fine. So I'm going to take the screenshot. So 1, 2,
Remember,
3.
There's two pages of people on mine. I don't know if you've got the same, Dilip.
Yeah. So same here. So I have 2 pages.
I might need to get both of them.
Okay.
Yeah.
Well, I am going to wrap up, if that's okay. So just to say, our next session is the 30th of July, 9 o'clock to 10 o'clock UK time. And we're very pleased to say that Dr. Sherish Tawfiq from PIL will be speaking on her experience with the Heartbeat of Pakistan Roadshow. So we look forward to seeing you again. And again, huge thanks to our speakers today for a very lively session and for you all joining on behalf of Bilal and myself. Thank you very much.